Hello, my dental professional friends. You are missing out on an additional six figures of revenue in your practice or in your paycheck by not having myofunctional therapy in your practice. Did you know that it's not just for sleep? There's actually so much more that you can do with myofunctional therapy, even as a general practice or as a specialty practice. There are lots of practices that are making an additional six figures by adding in myofunctional therapy, and it is sometimes some of the best thing that's ever happened to cutting down additional costs in the office. If you are remotely interested in myofunctional therapy, this is a lecture you don't want to miss. And if you are struggling with where you are professionally in dentistry or where your practice is, this is one that you definitely don't want to miss. So, I'm your bio best friend, Karese Laguerre. I am so happy to be here. I am here with you on a regular basis to provide value always. I don't believe in gatekeeping. I've got over 70 hours of content here on YouTube or on LinkedIn. So, wherever you are, subscribe, connect, and get in the loop because that's the only way we're going to advance to excellence. Nothing has ever pushed society forward by creating more walls. So, we have to be open about the information and the knowledge that we have. And if I am able to help practices over the country, here in America, just to be clear about where I am, but if I'm able to help practices all over the country implement myofunctional therapy with hands on systems, with me personally there to help them implement this into a six-figure revenue system, why would I keep that to myself? Why would I put that as something that you can only get access to if you pay me money? No, here we are live for free. Join me every single week. Let's keep this rolling. Okay. All right. So we all know that mouth breathing, in and of itself, just mouth breathing, can contribute to a disaster or sequelae of events. So we've got periodontal disease, which we know can be linked to mouth breathing because a lot of the anaerobic, so those oxygen deficient or like they don't thrive in oxygen, so they want to be outside of oxygen, and those anaerobic bacterias, those are the ones that thrive in those dry environments, and we create lots of opportunistic spaces for them when we are mouth breathing, because physiologically it just creates the additional space, the inflammation within the gingiva. It creates the environment that hosts a lot of this bacteria, in addition to parafunctional habits and all sorts of other things. But mouth breathing specifically contributes to periodontal disease. We don't talk about it enough as a profession, and we really need to. We should. It contributes highly to a gut imbalance because we're adding and contributing additional air into our GI system. It's leading to inflammation within there. And so we've got like things like inflammatory bowel disease. We've got leaky gut, very much connected to mouth breathing. And that's a big thing that we see a lot of people struggling with and are able to help them get on the other side of once they are eliminating things that do contribute, such as mouth breathing. Tonsil stones. There's no filtration system when you're breathing through your mouth. The tonsils wind up getting lots of other things stuck within them, including food or whatever other debris. If you're a chewer and you put things in your mouth and little pieces of pencil or whatever you might be chewing on wind up there, guess where sometimes those get lodged? Right in your tonsils. And then that creates a barrier where now the body is trying to protect you, and now you've got a stone. Salivary content changes, dry mouth. I mean, I could have a whole lecture just on this alone and how everything really comes together. And trust me, we've done lots of lectures about things that you'd be surprised. But what I want you to know is that mouth breathing is entirely within the realm of myo and definitely within the realm of dentistry, because so many of these things are attached to our work area. this is where we are. This is where we work. And everything has to do with how the muscles are functioning that support this work area. What is happening with oral facial dysfunction very much contributes to what we're seeing in our chairs when the patients come and they sit down and they reveal all sorts of things that have been going on, or when we look in there and we see what's been going on. So, what exactly are you waiting for? You know there's a problem, you know there's a solution. Are you waiting for some magical course to come along that will make you feel like, oh my gosh, I know so much now, I'll be able to implement immediately? No, I think you're really just waiting for it to really make sense and to understand how this could possibly be working in the practice. So that's what I'm here to help you with, because it's confusing. You hear about people doing it. Sometimes you hear about people doing it and it doesn't sound like they're doing good at it, or it sounds like they've got themselves in issues with boards and board complaints or other professionals, and it seems like there's some hierarchy and some war, and so you're like, what is the scope around this thing? It becomes very, very confusing, and I don't want that for you. You don't have to think of Myo as just being something that you can implement and do. If it is a sleep practice, if you're doing tongue ties, if you're doing ortho or expansion, general dentistry can do Myo. Specialty practices like periodontal practices can do Myo. You can implement Myo. You can successfully do it and never utter a word about their sleep. As far as you uttering it, they might come to you and be like, oh my gosh, I've been sleeping better. But if you're talking about perio and implementing Myo in a periodontal practice, I can't tell you the amount of people I've talked to that have done it with success. I can't tell you the amount of people I've been able to help. Like, it's so integral to part of what we do already. So all of your clinical stuff is still incredibly important. You still need to have your periodontal protocols. You still should have protocols around mouth breathing and xerostomia and what do you do with all of that. But in addition, you can have a holistic support program that will help too. But how do you get it in? I get it. That's the confusing part. Let's end some of that confusion, because my goal for you today is that you are going to enter into myofunctional therapy as a thought process, as a conceptual thought process that you can have into your practice from a place of strategy, as opposed to a place of desperation, which some of you watching might be in a place of desperation where you've already invested in a course. Listen, we know dental professionals lose their investment in the course at 3 times the rate of other professionals because we don't know how to implement it appropriately. People are gatekeeping this information. There are consultants who charge exorbitant amounts of money for this. You could get it in your intro course. I hate intro course. It's such a disgusting term to me because they're never priced as introductory courses. But if you take a comprehensive course, and there's only one I know of so far, but if you take a comprehensive course in myofunctional therapy, it includes on-site implementation. So you don't have to enter from a space of desperation. I've invested this money, I need to make it back. And now you're word vomiting everything about myofunctional therapy and oral rest posture to a bunch of people who really don't care about that. We can do this strategically and smart, and we're going to. Okay. So let's think about systems and how systems work and why systems are important. Systems absolutely give you a point of which you have something running. So, one of the biggest things that a lot of the dentists I speak to always talk to me about is like, what happens if I lose my hygienist? What happens then? What happens if they become so passionate about this that they are now gone? And like, how do I put somebody else into another course and then I lose that person too? Like, this is way too risky. It could be risky, or you can enter from a place of strategy where you have a system around contracts, you have a system around how this is implemented, you have a system or lifetime access to a course and course content and continuing education by that provider, by that instructor, by that organization that you can tap into, so that now this gear that may have walked off is not the end all be all. You still have other systems in place between the front end of your office, between your end of how you're looking, how you're screening. You still have protocols, you still have intellectual property around some of your forms and so forth. You have your programs that are intellectual property for your practice that, with the proper contract, nobody just walks off with, right? So if this is something you want to implement, you need a system so that you can plug and play anybody into the role. And let's be clear, let's be very clear. Everyone is replaceable. It's happened hundreds and thousands and millions of times over the course of history. We are not meant to be on this earth forever. When we are gone, somebody else has to come around and do our job. So if you don't have a system around how you're currently doing a workflow for anything else in your practice, definitely get one. But for Myo, it's incredibly important because you need to be able to know and identify where there is a problem, or if there's a shift, how do you put back that piece into the system? Because our goal for the system is to make sure that our workflow is so seamless, so smooth, that we can not influence negatively, at least, the patient experience. And that's all this is riding on, the patient experience. We need our patient experience to be as smooth and flowing as possible. So what are some of the essentials to integration? Well, we're going to go over 5 pillars today that you need to really think about and consider. And if you haven't thought about it in any capacity, now's the time, okay? So, first one is how to work with your ideal niche. You know that there are niches within Myo, right? Like, you don't have to work with everybody. If what I was talking about with perio before is your thing, you can only implement Myo programs for periodontal patients specifically around a symptom, a particular dysfunction. You could do that. So we're going to talk about that. How to convey that, because everybody seems to think that we don't work in sales because we're healthcare providers. We absolutely do. Every interview you've ever been to in your life, you sold yourself to somebody. And so we're all selling, and that's okay. It's natural, it's normal, and I want you to really embrace that aspect of what we do. So how you convey that, we'll talk about. How to maintain scope. That's the number one thing, and not enough people are talking about it. Everyone is willing to sell you a course. Not a soul is willing to tell you what you can and cannot legally do with that information. You're going to get it here. Okay. You're welcome. Understanding how to deliver those outcomes. So, how exactly do you take what it is you know and start to implement it? And what does that mean as you're implementing that within the practice? So, like, how do we create these little programs and how do we get it in the practice? Like, how do we get that to turn into income, into revenue for the patients, for the practice, for the practitioner? How does this all work? So we're going to dive into all 5 of those. Okay. So starting off with number 1, we want to make sure that we understand like how to work with our niche. And it's really important that you understand your current workflow right now. You have to be able to map your current flow. What happens when a patient comes in the door? Do they go to the front, sign themselves in, at that point, sit down, and then it's immediately the RDH. The RDH comes and gets them. Then the RDH does what they have to do, or as far as like exam not exams, as far as x-rays. Can you tell I haven't been in clinical for like a minute? It's been a couple of years. But if they do the x-rays, and then it goes to the DDS and they will say, okay, everything's all clear, all good. And then they go off and they go do their operatory or their restorative or whatever they're going to do. And then the RDH comes back, they do what they have to do. And while we are scaling, oftentimes, I don't know about everybody else, but oftentimes that when I'm talking to everybody. So I would start talking to, oh, this is what I'm seeing. I'm seeing this. These are things that we can do. The doctor noted this. this is a program that we have for this. Oh, okay. So like we're talking through everything. So now we went RDH, DDS, RDH, then back to administrative. So the administrators are now going to be the people who are doing all the treatment planning and scheduling and so forth. And then they're out of their way. Well, that's good. That's a flow. We would have to figure out now if we want Myo in there, where does Myo fit into the flow? How can it be seamless? Because we don't have time. Who has time? Is there somebody sitting around twiddling their thumbs just waiting for their next patient? Because last I heard, from a lot of what I've seen, people are moving through appointments. People are booked out. You feel like you can't even take a vacation, because if you take a vacation, you're disrupting the flow. Can you imagine? We have to push all those patients out to like 4 months later. They can't even get an appointment within this week. So if you are struggling and you don't have time, how do we add this in seamlessly? So first start out by mapping what your current flow is like. Then what are the roles that happen within that flow? What does the hygienist do? What is the hygienist responsible for? How are they a player in all of the things that occur? Oftentimes they spend the most time with the patient. Like, we are the practice. Hygiene is the practice. There may be somebody else's name on the door or somebody else's name on the building, but we're the practice. We're the face of the practice. Well, they say that the front is the administrators are the face of the practice because of the first people that you see. But oftentimes you're coming for specifically your hygienist, to the point where it's a whole thing where if you're out and you are away and there's a temp in, they're like, where's Jenny? I miss Jenny. Like, you're not Jenny. All these things, they come for us. So we spend the most time with the patients. We're probably more likely to be able to speak to the issue more appropriately, to identify the why. Oftentimes they come and they'll sit, or maybe they'll roll their eyes at whatever we're saying, and they will respect the doctor more. So the doctor comes by, says the same exact thing that we said in just a little bit of a different way, and suddenly, like, all of the angels came down and now they understand the why so much better. So oftentimes, maybe they like us, but they respect the doctor. And so there's that little bit of conflict. Sometimes it's the other way around. What is it in your practice? And be real. Be realistic about what your role is and how you are seen from the patient's perspective. Because as you're mapping this flow, you've got to know what they feel. That way you can fit Myo in where it goes appropriately. So Myo for screening, Myo for explaining, because that's the why, like why we would need to even do this. The in front should always be able to know and identify how exactly this fits into all the treatment plans. And we'll talk about that a little more in a second, but they're sometimes the face of the office too. They can do a lot of the scheduling. They might be the people answering the phone calls. They might be the people doing the follow-ups. How much do they know and understand? Where does Myo fit into the flow for them and what they have going on? And they're busy. Our front office rock stars, they are absolutely swamped sometimes with things to do, and don't even get into the insurance. Like the people who are calling, verifying, and doing all the insurance claims, benefits, and frustrations, those people are extra busy. Like, how can we make it easy and seamless to fit it in? You have to know where your current flow is in order to put anything new in. This is what I'm talking about with systems. If you don't know what's going on currently, you're going to struggle to implement Myo. You're going to try to implement it as it's like some quiet back office thing that just the hygienist talks about. And it doesn't work like that. Can you imagine if you're trying to explain what an OMD is, and then they go to the front and they're like, the hygienist said that I have a TMD. I have a what? And then they look at the notes. The administrators look at the notes and they're like, OMD? Oh, she probably misspelled TMD. It's your jaw. Like, is something going on with your jaw, honey? Like, no, nothing's going on with my jaw. I didn't have a problem with my jaw. They were saying something about like my tongue or like whatever. I don't know, something about the TMD. We got a great program for that. The doctor can make you a night guard. We're not here for that. Like, we're not talking about that. Like, you have to understand what an OMD is to get what the flow is. And then to now, it just wouldn't make sense if they don't know what they're talking about. So you have to be very clear what the flow is, and then like what exactly it is we're all talking about. So an OMD, for anybody who is unclear as to what an OMD is, it's an oral facial myofunctional disorder. For everybody to gain true clarity, that's an over or underutilization of some oral facial musculature. In some ways, it could be related to breathing, chewing, swallowing, digestion, heart rate variability, like yada, yada, yada. Okay. So, what I like to implement is a quick screener. And this is like the point where you need to figure out who it is that you want to work with and niche down. Okay. Brooms, I love. I co created Brooms. Brooms is a like quick for hygienist by hygienist thing. It is no nonsense. I wrote about it multiple times. You could find it in RDH magazine. You could find it in Sphere. You could find it in Dental Sleep Practice, Dental Sleep Practice magazine. Let's go do this really, really quick. It should take you no time at all. So whatever you're implementing in your system and in your workflow to help you quickly identify who it is you're working with and why, it needs to be seconds. Seconds. There are lots of screeners. Some of them are fair and others are more fair that aren't literally labeled such. But make sure that it takes you seconds, because you shouldn't have to have additional education on something in order for it to be an appropriate screener for the dental practice. And I hope that that makes sense. How long does it take you as a dental practitioner to identify whether or not someone's a bruxer? Seconds. Absolute seconds. You don't even have to ask them. Sometimes they don't even know you're looking at the occlusal wear. You're looking for wear facets. Like, you know what you're looking for, and you can see and identify that. Is there attrition? Like, what's happening? Yes or no? Respiration. How long does it take you to determine if somebody is breathing and you can hear it if it is audible? You're sitting over them oftentimes for 45 minutes or however long you're sitting with them. You could hear it. It's not something that you need to take out like a measuring tool or you need additional education on. This is what I'm talking about with fast assessments for dentistry. There is nothing I hated more than to have somebody come into our office and try to like teach me something new about whatever for like a lunch and learn, and then want me to do additional screening and whatever. Like, I don't get paid for doing extra because you came by as a physical therapist and you gave me some screening form or some referral form for your TMD. I don't get paid extra for that. So if I have somebody who's TMD and the doctor wants to refer, I'm happy to hand out your card. I am happy to send them to the administrators at the front who might have time to actually hand them your card, because I have to go back to the back and get ready for my next person who's already been sitting out there for however long and I haven't peed in 3 days. But these things need to be quick. Orally defensive. If you are fighting for your life, trying to look into their mouth and you can't get in there, the tongue is pushing you out, that lip is covering and it is like trying to break off your finger if you're trying to retract that lip. These people are orally defensive. Do they have open mouth posture? Are they sitting in the chair with the model mouth? Yes or no? Maxillary transverse width, is it wide? Is it within normal limits? Is it narrow? These things take seconds, absolute seconds for you to identify. Two or more positive in that affirmative column. So yes, audible, yes, yes, narrow, or yes, is going to be a sign that you need to either refer or intervene. Okay. And this is where we're going to get into, okay, so now I know there's a problem. How do I convey this? You want me to tell people what? Like, what exactly is it? To start the combo, you have to know what it is that you're going to talk about and how exactly you would like to lay that out. So, how would you bring up periodontal disease? Some people have really great analogies that they've already brought up to their patients. If they like to talk about floss, I have a hygiene friend who likes to talk about takeout food when they're talking about floss and like things just sitting. So if you have a container takeout food and you leave it on the counter and you just don't, clean it up in a few days, would you go and put that in your mouth, this takeout food? Like, ew, no, that's nasty. Well, sometimes you eat and food gets caught in between and it's trapped under your gums for days and you're not flossing or whatever, and it's still in your mouth. So you have this discarded food that you wouldn't put in your mouth if it was external to it, that you're keeping in your mouth internally. So you should maybe floss. That's a great analogy. It works really well for that person. I had my own thing that I used to like tell people all the time about that, and flossing and like, what was the importance of it. But like, how would you traditionally start a conversation? Hopefully, if you're an analogy type of person, you can develop another type of analogy. However, I would say if you're just as real, raw, and honest as you can be, I think people really like that. I can't tell you how many people I follow now or I really do appreciate, because it doesn't seem like they're put on, like they're trying too hard. They're just being themselves. They're giving it to me raw, real, and like rapid, which is what I like. I don't want you to drag something out for you to try to get my attention and then misdirect me. I don't like that. We're all scrolling through social media. Everybody's getting a bunch of that all the time. We don't need that from our trusted healthcare providers. What we need is real, raw, honest conversations. Like, I crave the real. And so you can, mince words around Myo, or you could be like, look, I can help you with some simple exercises that'll get your muscles back in gear, because your muscles are really messing up your mouth right now. This periodontal disease or this gum disease that you have, it's only getting worse because of your mouth breathing. So we've got this program that we implement in the practice. It's all natural exercises, but you got to commit, honey, because if you can't commit, if you're not brushing daily, if you're not flossing daily, you're not going to get your outcomes when you come here. So if you're not doing your exercises, you're going to continue to not get the outcome. Can you commit to doing some exercises 5 to 10 minutes a day? I've got a great low cost program, very holistic. We've got some evidence behind it. Like, I can get you started on that today. Does that sound good? Okay, yeah, I can commit to doing some exercises. How much is this thing? And I would be more amenable to that than somebody trying to like word vomit a bunch of stuff about, what's going on and anaerobic bacteria and things are breaking down and my saliva and I have xerostomia and something's not working and what? Just give it to me real. I'm messing up my mouth and I don't want to mess up my mouth. How can I make it better? Right? So I think it's incredibly important that it's not even just you as a practitioner that knows how to convey, but if you were to tell somebody that they needed a root canal and you talk to them about why they need a root canal, and then they go to the front and the treatment coordinator is unsure of what a root canal is, why you need it, and how to really explain it, and so they need to call the practitioner back up. Like, this just seems disorganized. Like, why y'all even offering this thing that you don't even know about? Root canals. You don't even do root canals here. I'm going to go find an endodontist. Like, thank you, but no thanks. I'm not going to do my root canal here. So I think it's really important that everybody knows how to convey these things. And so it's important that everybody talks. As you are mapping your flow, you need to have a very open and honest communication with everybody on the team. The whole team should understand what's going on. The whole team does not need to take an introductory course to myofunctional therapy to understand what's going on. Stop believing that lie. That is just meant to line somebody's pockets. There are over 70 hours of content and information here. There's lots of great reading. We live in the information age. If you need an assembly of resources, email me for an assembly of resources that you can use for your office, for your team, to help everybody get clear on what it is that's supposed to be occurring. Okay. So it's important that everybody understands and is on the same page. That's the best way to be able to convey it. And I want you to be real, raw, and just cut to the chase. The third thing is understanding scope. Can I tell you that the number one thing is that you really just have to keep these things separated. It cannot be myofunctional therapy in the true sense of myofunctional therapy. It can't be oral myofunctional therapy. It can't be oral facial myofunctional therapy. It can't be oral facial myology. It can't be just plain old myofunctional therapy. It can't be none of those in the dental practice as a dental hygienist, I know there are offices with dental assistants or with front office administrators who are doing this. It's not that while you're in the practice. Okay. That's why you guys are getting in trouble with your boards and so forth. I have not one, but 2 lectures specifically on scope that will get you very clear 100% of the way. And you can ask me for those. I'll be happy to put it in the comments. But you have to keep them separated, or you go full airway hygiene. Airway hygiene is its own sect that keeps it entirely in the scope of practice of a dental hygienist. I have a whole freebie opt-in that I gave out a while ago. I'll renew that. But where I went through all 50 state practice acts and I found all the terminology that validates airway hygiene. Not myofunctional therapy, because it's not written into any dental state practice acts, and where there are practice acts where it's not written into any practice acts, but where there are boards who have had the discussion. Boards are regulatory. They've all said it's got to be separate. So make sure you're maintaining the separateness. You can't have them together. It is not a real myofunctional therapy in that way. Yeah, that was that. Okay, so you have to understand how to deliver your outcomes. I do want to go back for a second to developing your talk because I think my slide got moved. I don't know how, but that talk, developing your talk, was supposed to go up where we had the cow manure. Okay, let's talk about how you would develop a talk when you're in chair and you're trying to connect with your patient on exactly what it is that you're finding or what it is that you intend to work on. You want to insert the pain point and what the connection is and make sure that that is the most clear thing possible. Okay. What is the deeper why to this? I'll tell you that people to a point care about the things that you're trying to actually solve, but there's always something deeper. When we say we're helping people by delivering smiles, by changing smiles, we're helping people one smile at a time. There's not a smile in the world that's been worth the amount of money that people pay for it. What they're paying for is a different outcome. What they're paying for is the ability to be in social rooms and gatherings. They're paying for that. They're paying to be able to smile at their daughter's wedding and to be in those photos. They're paying to be confident enough to show up on social media, to show up and present because they've got a big presentation for work coming up. They're paying for the ability to not feel embarrassed anymore in front of their own children. And so they don't have to like hide or talk funny or whatever. They don't want to be embarrassed in front of their children. They're paying for something much deeper than whatever you're trying to sell. So if you're selling a full mouth rehab, if you're selling just veneers, if you're selling whatever, that's what you are looking to do. That's your clinical aspect of things. That's what you're billing out to the insurance, or that's what you're putting on the treatment plan, like veneers, crowns, whatever, implants. But what are you actually selling is the ability for them to be able to insert thing here, smile at daughter's wedding, yada, yada, yada. You're selling that. That's what they're paying for. I will pay you a lot of money if I feel uncomfortable at my daughter's wedding and I need to feel comfortable. And what you can do will help me get there. I will pay a lot for that. I will shop around if it is veneers just for the sake of getting veneers, or it's a crown just for the sake of like, oh, I need a crown. I There's no motivation for that. And we are not in an economy where there's a bunch of people running around with disposable income all over the place. There's actually a better economy for like travel medicine and travel dentistry, where people are going to other countries and documenting that on social media. So they're price shopping because you didn't sell them what you thought you sold them. You sold them implants, they went somewhere else to go get implants where it was cheaper. What you need to do is make sure that you create a connection that is deep. Dig deep. What do you know? What kind of rapport have you built with this person that is sitting in your chair? Ideally, you have some level of rapport where you know something that you can connect to. So, if it is the periodontal disease and you're doing programs specifically for mouth breathing because you're concerned about the periodontal disease and the periodontal disease progression, and you know that they just got married, or you know that they're trying to conceive, did you know that mouth breathing can be a contributing factor in having reproductive issues? Were you aware that the periodontal disease, this gum disease, it's reflecting to me that there's already some issues with the mouth breathing, and I don't want that to extend any further through your body than here. I don't even want it here because this is my work area. This is the part of your body that I care about because I have to work here. But I care about you as a person. I know you just got married. I know this is the next step for you. You're really excited about it. You guys have been trying, and I've been seeing you every couple of months, and I'm so excited. I know it's coming. I know it's coming. You're going to tell me you're pregnant one of these days. You might even be pregnant now. Maybe you don't want to tell me because it's the first trimester or whatever. But this mouth breathing might be associated. So you want to have some sort of connection that runs just a little deeper, because that's the best way to connect with people. We get marketed to all the time. All the time. You're listening to podcasts, it's in the podcast. You're listening to music, there are ads interrupting your music. You are driving, there's billboards everywhere. It's all over the place. Even when you're looking at cars in front of you, a lot of times they have the dealership on them. Like, that's a form of marketing. You are being marketed to all the time. Somebody who connects with you, now you're listening. It's not even just a marketing tactic. Now it's a connection. I'm listening. I'm prepared. And you want to rehearse. And when I say rehearse, I don't want you to have a script. I want you to just start talking, even to yourself in the mirror, but talk to another person if you can, and really just start to connect and get comfortable connecting on the topic of myofunctional therapy, on the topic of TMD, on the topic of mouth breathing, on the topic of vagal tone, these things that we'll talk about in a second that you can actually work on in short programs for the dental practice. And then make sure you use it at the right moment. Like, don't make it awkward, okay? Don't talk to somebody when they're not ready to hear it. Don't talk to somebody when they have something major going on in their life, or where they come in and they look really stressed. You don't want to use it as, a sales thing and be slimy in that way. You want to talk about it as a provider who cares about the person in their chair, and therefore now we're talking about this, and it's happening at the right time in the appointment when they're ready to receive this information, where you can look eye to eye, where you could be level to level, and you can really connect with them. Okay, so that's developing your talk. Okay, let's go back into how to deliver the outcomes. So a lot of people think myofunctional therapy looks like one thing, and if you've taken the wrong course, which thousands of people have, you also think it also has like one set path of exercises, where you literally visit one is visit one, visit seven is visit seven, and it doesn't matter how they came and what their issues are, you're going to do the same set exercises for everybody. It's kind of ridiculous. But you can do a full program, yes, or we could start treating people like individuals and understand that there are some people with some low level concerns, or people who need a bit of intermediate care. who could use a little bit of triage before they're referred out for a full program. So don't go all, they took our jobs. No, I'm not saying that myofunctional therapists are irrelevant. I'm saying that if you're going to implement it in a dental practice, a lot of times, so yes, you could do a full program, but a lot of times, smaller programs are very, very successful financially, time wise, professionally, because it's less for you to have to learn and manage and really keep on a whole separate hat of knowledge for. It is something that you can do for tongue ties. You can just really pre and post, prep and recover, like really plug and play. Mini Mayo, working with all those little ones between the ages of 3 to 5. TMD, you can do a low level program with TMJ. And can I just say right now, actually, while I have your attention, that I am working on and actually finishing it this week. And so we need to chat. If you're interested in a TMJ program, I need some beta testers for a new course that's coming out that will have everything literally so that you can implement a low level TMD course. TM Low level abbreviated TMD program, myofunctional program in the dental practice. But that is coming out very soon. If you're interested in that, let me know, or let's chat or email me if you know my email. But yes, anywho, let's carry forth. So TMD, OSA, obstructive sleep apnea, breathing. You can work with breathing, mouth breathing, or just breath work programs, or vagal tone. What you cannot abbreviate is oral face swallow retraining, unilateral mastication, trauma, congenital disorders, sensory issues, structural breakdown like occlusal wear or breakdown and insufficiency. I don't like that that is ringing right now. I really have to, it's on the other side of the office. Okay. Structural breakdown or insufficiency. So you can do programs that are very focused if you're going to do abbreviated. You could also be there to help if they're going into surgery, like oral maxillofacial surgery. And there are some practices, shout out to my practices, they know who they are, who are just oral surgery, and they have myo there, pre and post in the practice, already established. You can help people with nasal hygiene and establish just nasal hygiene programs. Or you can help with sleep hygiene and just work with sleep hygiene. You could just help them enhance their awareness around their muscular use or their parafunctional habits. You can help them eliminate oral habits. You can help them develop some better orofacial muscular skills or strategies around how they manage stress, particularly when they have parafunctional habits. These are all things you can do with myofunctional therapy that have nothing to do with you being an airway practice. You could do that in just a general practice and find a lot of success. It's not something that has to be overly complex. Um, I've done it numbers of ways. I've done like specific programs and helped people triage down what's like over 85 exercises. And if you're taking my comprehensive course, into like, here are your set structures. This is what you need to focus on in order to implement this low level pre and post operative program. This is how you can structure it, or this is how we should whatever, and let's create all the content around it, whatever. And so it's really, really, really effective. And I think that the best part of it is that you're doing so much more as a practitioner than just your traditional role. And that's the problem with dentistry in some ways, is like dentists feel like they hit a ceiling. You own a practice, like what else is there for you to do? Own multiple practices, be more stressed out, spend less time with your family. Like what else is there for you to do? If you're going to be a hygienist, like it feels like you've hit a ceiling. Like, I've maxed out on the things I can really help my patients with. Well, now you're adding to, you get to contribute so that you don't leave your current role, and you build additional income. So you're able to really help more people and help yourself at the same time. So the fifth aspect that we're going to get into is how you implement it within the practice. And implementing in the practice really just comes down to if you're doing a full program, if you're doing full programs, it looks entirely different. And we can do some math about that. But what I want to do right now is some math on these low level programs, okay? Because a lot of the practices are doing the low level programs at, let's say it's $360 a year. Okay, so if you're doing $360 is going to be our program for the year. Just so you can see, that's $30 a month. Okay, so how difficult would it be to get somebody to sign up for a $30 a month program to eliminate a parafunctional habit that is going to contribute to the degradation of their periodontium and further their cost for, I don't know, now they're looking at flap surgery, or we could try this instead, right? So then that's 3 to 5 daily patients on average that you might have accept that. Let's say the practice in totality has one hygienist, one doctor. Doctor's column has 8 patients. Let's say the hygiene column has 8 patients. And there's 3 columns altogether. Doctor might have 2 columns and 8 patients. Hygienist has 1 column and 8 patients. So that's 16 opportunities to discuss myofunctional therapy or an abbreviated program that you do, a focused program, and 16 opportunities for you to now pitch this thing. 3 to 5 accepting it on a daily basis is $1,440 in daily revenue. But then if you're working and your practice is open 5 days a week, that's roughly $7,200 in weekly revenue, which if we continue on with our math, that weekly revenue, well, we time that by 26 weeks. Let's say, you're working, and that's $187,200. Okay. Wow. 26 weeks, 6 months. So by June next year, let's say you implement it late December, early January. By June next year, that's almost $200,000 in additional income. What can that mean for the practice? Well, if you're partnering and it's a hygiene and a dentist that are partnering, for additional income in this way, and you're doing these low level programs and you're implementing these programs literally chair side. So chair side, you're doing it as the hygienist, or it's being distributed in another mechanism of action, because there's a bunch of different ways that you could do this. And I'll talk about that, or I've talked about that, I should say, in my abbreviated programs lecture. But I will talk about it again in an upcoming lecture, because we're about to hit our time for today. If you're splitting this income, let's say just 30% goes to the hygienist, just 30%, because it's the whole team that's actually implementing all of this, all of the supplies and whatever, everything's coming from the practice. And so 30% is essentially like what we're looking for when we're trying to look at profits for the practice, like our production and what we're bringing into the practice versus what we make. We try to average that out as like a third. So average this out as a third. That could be an additional $55,000 in half a year of additional revenue. $55,000 in your paycheck as a hygienist, and an additional $130,000 for the practice that could be evenly distributed amongst the whole team. Kind of seems like a no-brainer almost in some ways. Like, why would we be missing out on this opportunity to do this? It just seems like something that It helps the patients, it could help the professionals, it grows the practice, it builds in a little more loyalty. Our patients are now sending their friends and family, like, this seems like it might be a pretty great method to go through. Ah, interesting. So it sounds like a great idea. It's absolutely a great idea to implement Maya. But when it sounds like a great idea, it's good to have a great idea. But the important thing is always going to be the implementation of that important thing. Okay. You have to implement it the proper way. And so there's only one way to do it. And that's by getting real clear on what your goals are and where exactly you're looking to go, and how you plan on getting there needs to be structured the right way. So let's chat. I talk with a lot of people all the time. More often than not, I'm telling people to, do something else. Like, you don't have to do the content that I have out there. Sometimes I tell people, this one isn't for you, or two, you need to go to talk to this instructor because perhaps they would be a good fit for you. So don't feel like you're going to fall into a sales pitch. We're going to talk because I'm your Myo best friend. And if you need clear direction and guidance on how to do this, like, there's nothing I want more than for the field to excel and to progress more into myofunctional therapy as a whole. It just validates us all, and it gets so many more people towards my goal of us having a world free of any oral dysfunction. So, with that, my friends, I am so happy to have been here with you another time, and I can't wait for our next lecture. We'll be just growing and excelling together. Bye, friends.